Okay, good evening, everybody.
Good evening, everyone.
Good evening.
In. How are you, Dr. Mo?
I am fantastic. I'm loving this Hump Day Wednesday. I'm getting over the hump. It's
Right,
all good.
right. In a storm. We got a storm here, you got a storm there, but it's all good.
Indeed.
All good. Hey, so we have some amazing guests to talk about reconstructive surgery and what your choices are.
And background noise.
There we go. So that's me. I'm going to start, and I want to introduce some fantastically phenomenal folks. The first person I want to introduce is Erica Hill. Erica Hill is my lovely, lovely soror. Erica, where are you hailing from? Atlanta, Georgia, correct?
No, actually, I'm in Detroit.
You're in Detroit currently, but where are you from originally?
Detroit.
Oh, you're from Detroit. Oh, awesome. Okay.
I'm from Detroit. I am home, but I do live in a very sunken place called Nashua, New Hampshire.
Oh my, that's right.
That's a beautiful place. You know, I went to Dartmouth. I love New Hampshire. It's beautiful.
Oh my goodness. Wow. I want to welcome you. You are a breast cancer survivor and thriver, and you have had a reconstructive journey that you're going to tell us all about. And you are with your cousin, who is also a member of the D9 and family, Dr. Griffin, Dr. DeLorean Griffin, otherwise known as Dr. Nip and Tuck. And I have to read this bio because this brother's bad. But here we are. Dr. Griffin is a plastic and reconstructive surgeon at St. Mary Mercy Hospital in Livonia, Michigan, board certified by the American Board of Plastic Surgery, focusing on breast and body contouring following massive weight loss, and also performs up-to-date breast reconstruction and complex reconstruction for trauma. Dr. Griffin completed his medical school education at Wayne State School of Medicine and his residency at Detroit Medical Center. It should be noted that he is a proud alumnus of the Florida A&M University in Tallahassee, Florida, highest of 7 hills, as is Ms. Hill. And during his training, he received the highest in-service exam score in his program 2 consecutive years in a row and was promoted to chief administrative resident. He has won several awards, including the best reconstruction resident presentation at the American Society of Plastic Surgeons in 2014. And single-handedly, get this, because I tried out for Jeopardy, Dr. Griffin has also single-handedly won the resident Jeopardy competition in Mackinac, Michigan. You were named an honoree for Michigan Chronicles 40 Under 40 in 2017, Men of Excellence 2018, recently recognized as top doc in the field of plastic surgery. You are committed, Dr. Griffin is committed to educating residents and students in the field of plastic surgery and the community as well as abroad. And he serves on the executive board of the Detroit Medical Society and is a financial member of Omega Psi Phi Fraternity Incorporated. So I am so pleased to welcome them. I have one additional guest with us here today, our additional soror, Yasmin Coleman, who is an activist. She is a 2-time breast cancer survivor, first diagnosed in 2000 and more recently in 2020. She's happily married to Richard Coleman, her husband of 29 years, the proud mother of 2 adult children, Paul and Lauren. Yasmin attributes her strong faith in her husband's support and unconditional love in helping her get through breast cancer, not once, but twice. Yasmin says there's nothing like Black love. When it's real, it's good. It's real good. And you too have a story to tell about your reconstructive journey after breast cancer. So I want to welcome you all to The Doctor Is In. And Ricky, you got some stats for us. You got some numbers. Let's talk about
numbers. Let's talk about it. Let's
talk about reconstruction in the Black community particularly.
Yeah. So overall, less than half of all women who require a mastectomy are currently offered reconstruction. That blew me away. Less than half, right? And fewer than 20% actually elect to undergo immediate reconstruction. I thought those are like really low numbers, right? Mm-hmm. Only 23% of women understand the wide range of things that you can do with reconstruction. So people aren't being educated about reconstruction. So that's everybody, okay, not just Black women. Following mastectomy, a lot of women report that it was worse than they expected, that they didn't get the outcome that they wanted, right? They're dissatisfied with the process and really not happy with the results, okay, a lot of women. So let's talk about Black women. Race alone is a predictor of who is most likely to undergo reconstruction, and that this racial disparity exists independent of geography or socioeconomic status. white women are 40% more likely to get reconstructive surgery than Black women. So we're not getting it in those numbers. Also, Black women are less likely to undergo immediate breast reconstructive surgery and are less likely to consult with a plastic surgeon about it. They're not being educated about it before they have their mastectomy surgery. And when they do get it, Black women are twice as likely to choose reconstruction using their own body, right? Basically using their own tissue instead of getting implants. And that may be because they're afraid of putting an outside thing into their body, but they use, and you guys can talk about this, how you use your, you get a tummy tuck. When you get reconstruction, you can get a tummy tuck or use your back fat. So all that stuff is more likely with Black women. So those are kind of the facts, right? The other one is that they may wait until after their mastectomy and do it later because they may not have the money to do it. They may not have insurance to cover it. And they may have, financial issues that could prevent them from doing it immediately under surgery. So that's kind of the lay of the land. But I think what it says to me is that people aren't being educated about what their options are. And then they may not get good information. And then guess what? Their outcome isn't what they want it to be.
I'm going to say this too, Ricky, because a lot of this work was done out of Penn Medicine. My good friend Paris Butler is a plastic and reconstructive surgeon there. And I don't know if you know him, Dr. Hill, but I'm sorry, Dr. Griffin, but the study really did normalize for all socioeconomic status, all insurances as well. So they looked at TRICARE in the military, and Black women just were not offered reconstructive options the most, but there is a confounder in that we are more likely to be diagnosed with later stage disease. Right. And so in the setting of later stage disease,
41% more likely.
Exactly. So, so Doc, let's start with you because talk about it. Right. So give us some information.
Yeah.
Because you're diagnosed at a later stage, and we may need post-mastectomy radiation, which can alter some of the reconstructive options and some of the cosmesis. So I want to start right there, and I want you to speak about your experience with Black women in breast reconstruction and just some of the challenges that you've had there.
Yeah, well, I was not surprised by those stats. The only one I was surprised by was the what we call the autologous reconstruction.
Thank you for saying that word.
Autologous reconstruction, right? So that means using your own tissue. So you have implant-based reconstruction where you use implants and tissue expanders to stretch out the skin and later put in an implant.
That's what I did. Yeah.
And that's the vast majority of patients, I think, across the board. But I didn't know that Black women were more likely to opt for autologous reconstruction. That was actually a surprise to me. And
a lot of fear about implants and tend to have a BMI that's a little higher and a little more tissue that's amenable to that procedure. So and I think also there are less concerns about things like hidden scars. It's just I have seen that Black women in general will get more of the deeps or the autologous reconstruction, as you call it. Some with muscles as well. But I wonder if we can start with your story. Sora, Erica, and tell us how you ended up in Michigan during a pandemic.
And tell us why you guys aren't social distancing, because people are going to ask why you're so close together. And
okay, well, that's a lot. So hopefully I remember all of this. So help me.
Because we both know that we're COVID negative because we get tested all the time.
Right.
Get surgery.
Exactly.
And I get tested.
You guys are related. So I was just going to say.
Right. So we are related. So Dr. Griffin is my cousin.
First cousin.
My first cousin. And actually we grew up more as, big sister, little brother. The roles have changed a little bit in this situation. So I was diagnosed with breast cancer in March of 2019. As part of my conversations with my doctors, I will say that I was encouraged to have a meeting with a plastic surgeon to discuss those options. And all of the options were presented to me. I will, be very transparent and share that I had already had a tummy tuck. So, that was not an option for me. I also had breast augmentation. And so, I was obviously very comfortable with implants. And so quite frankly, even prior to talking to the plastic surgeon, in my mind, right, I thought, well, I'll just get a different set of implants. We'll take these out and we'll exchange them for a better set, was sort of my mindset going into this. And that is what we did. And so I did get the tissue expanders. I had significant complications from the perspective of range of motion after that surgery, to the point that I had to cut myself out of t-shirts because I could not raise my arm.
Can you, one of the docs, explain tissue expanders to our audience?
Okay, so essentially, after a mastectomy, you're kind of left with a tissue envelope that's deficient in the sense that it's not ready to receive an implant, at least if you want to get a good cosmetic result. So in doing so, we during the reconstructive process, we insert these tissue expanders, and most of the time we use a material called alloderm, which is cadaveric skin that's been donated, that's devoid of any DNA components. It's just structural components. It's like skin. It just helps with the expansion process. So, you know, tissue expander, you put them in, and you either put them under the muscle, above the muscle. I think, you know, most of the time we put them above the muscle nowadays. You know, a lot of advancements have been made to where we can do that and result in preservation of the chest muscle, the pectoralis muscle. So
that's interesting. Many of my my plastic surgeons are still doing subpectoral implants. So the expander is a space holder, basically. You know, it's like a really tough water balloon, and it enables the plastic surgeon to be able to fill it up over time and not stretch the skin that's left over after mastectomy so much that the skin would die, because after mastectomy, we take away maybe almost 80% of the blood supply to that skin. And so we want to give that skin a chance to be viable and healthy. So we put something in that doesn't fill up all the space, like he said, that envelope, you know. And so over or under the muscle does make a difference in terms of range of motion, in terms of recovery, you know, pain, etc. And so we're still doing a lot under the muscle, and I'm seeing a lot of patients who have decreased range of motion and a lot of tightness, and they also get this, what we call animation deformity, where when they work out and they exercise, their breasts are winking, they're doing this because that pec muscle is jumping. And so the more you develop that muscle, especially in my nipple sparing patients, they have nipples and they're doing this, they're jumping, and it looks really odd to them, and they have a lot of, they're very self-conscious about that, you know?
Yeah, I think probably over the past maybe 5 years, there's been a push to go pre-pec, to go on top of the muscle if the mastectomy flaps are permitting. You know, you have to have a certain amount of thickness to them and blood supply to maintain, you know, that viability. But yeah, I think maybe I'd say probably about 75%, that probably 80% of my patients have undergone pre-pec.
And what Can I say something about the expander from a patient perspective? Expanders are horrible. If you want to know what it feels like, think of a milk jug, okay? And think of that type of material, and that's in your body. And it's horrible. There's no other way to put it. I don't think I've met anyone who said they like expanders.
Right, and you had to go in every 2 weeks and get them pumped up, right? I felt like
I went in every week.
Every week.
Balloon blown up in my chest, and you know, my little fake ones are bigger than the ones that tried to kill me, but still, it was like a nightmare to go in there, because it felt like you would have this tightness. They'd blow it up, and they basically blow it up until it hurts. Like, does it hurt yet? And then they stop. Like, you're like, oh my goodness, really? So.
I think I may have been a bit different in that I had to go every other week to get my expansions, because my skin was extremely thin, and actually during the immediate reconstruction, a portion of my skin, I'm going to use this term, I don't know if it's the right word, but it died, and so, you know, it had to be cut off. And so my expander was, if you can imagine, was sort of crammed in this really small space that also went a bit under my arm. But because of the condition of my skin, and as a matter of fact, I was very concerned, even though I think I had a phenomenal breast surgeon in the Boston area, I was so concerned that I flew home to Detroit and saw a breast surgeon here recommended to me by my cousin, just to have a second opinion, because I was very, very, very concerned, right? But in terms of the expanders themselves, maybe I'm not 0.0001%, that I really didn't mind them. It wasn't that painful. And maybe again, because my expansion process was a little bit slower. So I didn't have that same level of pain until the absolute last fill. And I was like, oh, so this is what everybody is talking about. This is really right, if you will. And so, but again, I did have all of the range of motion issues. I basically went to physical therapy 3 days a week for 4 months straight, just to be able to raise my arm at 90 degrees.
Wow.
So I was really excited to do the exchange, meaning get the expanders out and have the implants put in. And many people have asked me, so let me just go ahead and answer the question in terms of, well, you have a cousin that is talented and this is what he does. Why didn't you start with your cousin? The answer to that is, again, because I got immediate breast reconstruction. And so for me to have utilized my cousin, I would have had to delay the double mastectomy, come to Detroit, find a breast surgeon here and start that process all over. And my goal was, I want this cancer out of my body immediately. One. And then second, when I did the exchange, my thought process, I did it right before Christmas to minimize my time out of office because I was out a long time after the double mastectomy. And it was around Christmas time. And so my thought was, you know what, my mother came to me, she helped me. I had, a quote unquote phenomenal doctor in the Boston area, but please understand, I was on the phone with my cousin, like, hey, what do you think about this? What do you think about that? This is what I'm being told, etc. So he was consulting with me. What I can tell you is that after I did the exchange, I had breast implants, so I understand the implant process, but I can tell you that breast reconstruction and breast augmentation are two very, very, very different things. And even though this doctor told me, and I trust him with my life, I guess I thought I understood that, but I really didn't, because when the bandages came off and I saw myself, I thought, this is it? This is not what I was expecting. And I understand there's a process where things have to fluff and, do all of these things, but I'm saying, this is kind of Frankensteinish. This is not what I was expecting, right? And I still had the same range of motion issues. And so, just to sort of fast forward this thing, my thought was everybody had told me that, hey, when you do your exchange, your range of motion issues are gonna, instantly improve. Everything will be fine. You might need to go back in 3 or 6 months and, get a little touch up with that and fill some things in. But after 3 months, I had to take a look at myself, and in my opinion, I was deformed. He may be able to describe it very, very differently, but it was a horrible sight. I was very embarrassed, very self-conscious, and I just could not, set myself into the world, if you will, for people to look at me with these deformities. My implants still kind of were up in my clavicle, and they really shouldn't be there. They should be a little bit lower, and I had hollow. It was just pretty bad. And so at that point, so to the question around how did I wind up in Detroit in the middle of a pandemic, well, there were two things. One is, and I'll be honest, I had some reservations about my little cousin seeing me naked. So, so there's sort of that piece.
It's real. No, that's real talk, right? We got to talk about that because,
So it had absolutely nothing to do with his skill, but, I don't know that I want my cousin to see my breast. But when I flew home for the second opinion, he came with me. And so he saw it at its worst. And again, now we're talking about my quality of life. And I wanted to make sure I gave myself the best chance, because this was time number 2. And so I wanted to make sure that I was going to the best. I wanted to make sure that I was going to a doctor that understood me, that understood, aesthetically what would be pleasing, and the other factor was that, I live in New Hampshire. My doctors are in Boston. Massachusetts was shut down. There was no date with regards to when they would be open. And so to me, and I was at home in New Hampshire, my sunken place for 4 months by myself. And I thought to myself, well, these are all the signs are leading me to, fly home to Detroit, where I felt very confident and comfortable that I would get the best care. And you know what? I understand now that my reconstructed breasts, since I have no breast tissue, are not going to look as beautiful as my 36 triple Ds did from a breast augmentation perspective. But I also knew that this gentleman right here would give me the absolute best outcome that was humanly possible.
I want to go there with it, bro. Dr. Nip and Tuck, outside of your family member, right? So there's the pressure of, operating on your cousin who's really like your sister. And, we all cousins and sisters. And yeah, I know how it is. I was raised with my cousins too. And outside of that, you're getting now a redo, almost a redo, because you've had implant augmentation. Right. And then you've had mastectomy with implant-based reconstruction that we're not happy with for whatever reasons, capsular contracture, all the different things, whatever's going on there. So this patient lands on your doorstep. And for all the people who are watching who don't have the benefit of having you as their cousin, what can you tell these patients about what you counseled her as far as expectations, as far as what happened to her and what to sort of expect moving forward? Because there's a lot of people watching who wish they had a cousin like you to say, okay, well, here's what's realistic and here's what's not. Here's what can be done. Here's what maybe can't be done. So talk to me about that conversation when you see a patient like that.
Well, I mean, there are a lot of moving parts. A lot of times, you're dealing with patients that, have skin that stands out, radiated tissue, elevated, BMIs. You never know, how a patient's gonna receive the implant, and what you can do about it. What are your options once things have already been kind of established from a reconstructive standpoint. So I mean, my cousin in particular, I mean, just to get into the nitty gritty, she had a capsular contracture. There was the animation deformity. There was some bizarre hollowing that I hadn't really seen before on any patient. And, for me, I'm approaching this, okay, this is my cousin, but somehow I'm able to objectively separate myself psychologically and become a doctor. And it was no biggie for me. So we approached it as, what can we do? How can we improve the aesthetics here? How can we improve function? Because our left implant was laterally displaced. It was the same size implant. However, the skin
off to the side, right?
The skin tissue envelope was
like I'm a 5-year-old. Can you talk to me like I'm a 5-year-old? What does that mean?
Mm-hmm.
What's that?
Can you talk to me like I'm a 5-year-old? What does that mean? Laterally?
So it was kind of pushed out into our armpit. All right, sorry about the medical jargon here. So, then that happens for a variety of reasons. Sometimes the pectoralis, the chest muscle will push it in that direction. Sometimes the pocket is too big. So my approach was going to be, well, let's decrease the stress on the tissue by downsizing the implant. We did that on the left. I mean, on both sides, but on the left, we also collapsed the pocket. I did what's called a capsulorrhaphy. I took a piece of the capsule and obliterated it with a suture technique, and that moved it immediately or towards the center where it should be, where we wanted it to be. On the right, that became more of a challenge. I had seen some, bizarre things going on. I didn't know there was an infection on the inside. Thank God there wasn't. But I think what I saw was some fat necrosis, and she was very thin on the other side. And the alloderm, the cadaveric skin that we talked about before that helps that expansion process, was discolored in a way that, I don't know, it gave me pause. But we proceeded forward, and I released the capsule. I performed a capsulotomy, in that case, cutting into the capsule and modifying it. Again, downsizing an implant on that side. And then what every woman finds gets ecstatic about when it comes to breast reconstruction, she got the free liposuction, which is the fat grafting. So me personally, I don't know, do your reconstructive surgeons use the Revolve device?
Mm-hmm. Yes.
Yeah. So that's a device where we collect collect the fat into this device, and we are essentially purifying the fat, like Lake Minnetonka water. We we purify it. We rinse the fat. It's a lactate or ringer solution, and then it's processed in a way that gives us the most type of most viability that the fat can achieve, and then we re-inject it. So we did it. I think we corrected a lot of hollowing on that side, and then I think the other problem that she had was her breasts appeared kind of long. That's why I think the larger size implant was not the right size. And then so downsizing that allowed it to assume a more natural shape. And then we did some dog ear modifications. I don't know. I'm critical of myself, but because it's happy.
That's what's important.
So she talked about, yeah. So thank God she didn't need radiation, because then you get into, your only option is probably autologous. And then, like she said, she had a tummy tuck, so any type of deep flap is out. But there are other options. So she came over the summer last year. She saw Dr. Concrete Chayase, who was my mentor, and knows everything there is to know. Is the foremost expert on free tissue transfer. I mean, not just in breast, but craniofacial and lower extremity reconstruction and everything else, because he actually is pretty famous for reconstructing this girl that got mauled by a raccoon, a pet raccoon that her parents had, and they had to reconstruct this patient's ear, and I was actually a part of that. So he knew everything there was to know. I knew that if she needed an autologous reconstruction, I knew exactly where to send her, because that's out. But you can obtain autologous tissue or tissue from your own body from a variety of sources, including your inner thigh, your butt, the upper part of your butt, the lower part of your butt. Yep.
A lot of times we're starting to use, I call it the side meat. We're using the side meat over here, and we don't always have to move the muscle anymore. We can just elongate that vessel and rotate that fat around and put the fat
perforator.
Yeah, as well. I want to stop and give a couple terms for people who might be watching, just to sort of catch you up to speed on some things. So we're talking about breast reconstruction after mastectomy in particular. And usually what happens, many patients will end up with a, whether you have skin sparing or whether you keep your nipples, whatever type of mastectomy you have, then if you have immediate reconstruction, your plastic surgeon, your Dr. Nip and Tuck will come in and place usually what's called a tissue expander or a space holder that's wrapped in a thin layer of skin, like a cadaver skin.
I wish I would have grabbed it. I had an expander sitting right on my desk. I could have grabbed it and.
No worries. Do a quick video. We can post it in the comments here. For, later on in the week, people can watch it.
Send it to us.
Take a picture in your office, and you can post it in the comments, and people can see it. You also can see the fat, the liposuction that he talked about on his Facebook page. I think it looks kind of like an orange Julius or like a push pop or something. It looks like a dessert to me. I don't know why. I use a lot of food analogies, but not to gross people out.
It looks like Campbell's tomato soup.
It looks like soup. But basically, you end up wrapping your expander or your implant in that fake skin, putting it under your skin, and then closing it up. And then at some point after stretch it out, do we like the contour? Do we like the shape? They will then go back in, deflate those expanders, take them out, put the implants in. Now, when patients get radiation, so a lot of women are watching, I see some comments, well, I had radiation. Radiation is like leaving a rubber band in the sun too long. You know how you lose that stretchability. So radiated skin is not as stretchy, it's thicker. It is, the blood vessels are a little bit more tiny and they don't do as well after reconstruction, which is why he said you have to use autologous or your own tissue in order to fill in a lot of times after radiation. And I've done implant-based reconstruction after radiation many, many years later, but many times we'll want to use something that's yours, your muscle, your fat, your muscle from here. And, even like you said, from the thigh, and put that in after radiation. So if you're watching and you had radiation and you weren't offered implants, that could be why. And what happens is the body forms this smooth layer called a capsule. It's like the lining inside your mouth. That smooth lining inside your mouth forms around that implant. And that's the capsule that can get hard and make your implant shift the scar tissue makes it go over, right? And that's why you had to do the capsulotomy, the capsulectomy, the capsulotomy, the all the other stuff. You had all those words, all of the big words, $1 million words. The doc said, you got to break up the scar tissue and push things back over. So it's not a one and done kind of process, right? This is the thing, you know. And sorry, Yasmin, we talked about this. Remember I asked you, I said, if your surgeon had told you all of this might happen, would you have been able to even understand and receive all of this at the time of your diagnosis? So I want you to kind of chime in.
I think that the difference for me is that this was my second time. So the first time I went in very blindly. I was 42 and my kids were 8 and 5. And I just wanted the cancer removed. In fact, we were getting ready to move to Florida because I had accepted a position with Disney World. And I went in for a routine mammogram and found out I had cancer. So was on my left side. I had stage 1 DCIS, ductal carcinoma in situ. So it hadn't spread to any further than the ducts. So, so I went in for a wide incision, which turned out after that surgery, they found a small lump. I had to go back and have my lymph nodes checked to make sure that it hadn't spread any further, and it had not. So the recommendation for me was to go for radiation, and I did radiation for 5 weeks, okay? So fast forward to January 2020, I am diagnosed with breast cancer again. This time I'm pissed, okay? And I was very angry for several months because I'm like, what are the chances of me getting breast cancer again after 20 years, okay? And, you know, my breast surgeon had no answer because she hadn't dealt with anyone who hadn't had a recurrence before 20 years. So it was like, you made it this far, you're golden. So I'm a reader. And this time around, what I didn't have the last time was the internet wasn't as developed as it is now, okay? So I already knew before I went to see her that because it was the left breast and I had had radiation before, that I was gonna have to have a mastectomy this time. So she says, okay, good news, you're stage 0. She said, as long as you stay stage 0, there are some things that we can do, because I didn't want to take hormonal blockers. I was like, I'm 62. My quality of life is more important to me than something that's going to put me in menopause again. It's like, I'm not going to do it. I made up my mind, I wasn't doing it. So, anyway, so she said, the bad news is you're going to need a mastectomy. I said, okay, I already knew that. I said, what if I do a double mastectomy? She said, well, if you do a double, she said, it will, you'll have more symmetry. She said, you won't have to have, go in every 6 months to have a mammogram on the right side. And she said, if you stay stage 0, we do genetic testing and find out that there is no, it's not inherited. She said, then, and you get clean margins. You get clean margins. She said, you will not have to do hormonal therapy. So then COVID hit. Right at the week that I was supposed to have surgery. And so I called and said, am I having surgery this week? And she said, yes, you are. It would only change if the hospital says we can't do it. She said, but I don't consider this elective surgery. So that was my breast surgeon. So then I asked her to recommend my plastic surgeon. And I said, preferably a female. So she had 2 people. She recommended my doctor, who is a female. I went to see her and we had a very interesting conversation because I was like, can I go directly from mastectomy to implant? And she was like, no. And I said, well, can I do over the tissue muscle versus under the tissue muscle? She was like, no. And so, but she explained her no. So for me, the concern was I'd had radiation 20 years ago. She did not know how that left side was going to react, okay? So she was concerned about infections, plus the fact that I'm diabetic, but I manage it with diet and exercise. So my numbers are usually pretty close together. okay, in that they don't go over a certain range. So it was like, okay. And she kept saying, but you can get a second opinion. Well, at this time, I was only 2 weeks away from surgery. And it's like, you know what? Let me just move forward with everything. She makes sense. I may not agree with her, but she has my best interest in mind in that she is not going to agree to something that she's not comfortable with and give me less than satisfactory results. So I can appreciate that. Okay. So, so they explained up front, I go to sleep with my breast surgeon. I wake up with my plastic surgeon. 2 hours each breast, 4 hours for breast surgery, 4 hours for reconstruction. Okay. I guess the biggest thing was when I heard that I had cancer again and I was going to have a mastectomy or double mastectomy. It was like, well, I always wanted to get my breast lift. So I guess now, you know, I get to get new boobs. Yeah, that ain't true. Plastic surgery is not reconstructive surgery. I gotta describe this as when God made Eve, he picked up some clay, he molded it, and he put these two balls on her chest, okay? And so I remember, so I'm like, okay, so as I'm going through this expander process, the left side looks one way and the right side was like, it was horrible to me. I called the left side Edward Scissorhand and I called the right side Shrek.
That was a radiated side?
The left side was the radiated side, yes. Okay. And I remember reaching out to Dr. Mo and saying, look, I have these concerns. And she said, what disclaimer, whatever I'm telling you as your sorority sister, because I'm not your doctor. I don't know all of the specifics. But she said, rather than giving her pictures of what you want to look like, ask her some questions as to what you personally want, you know. And so in doing that, it helped. By the time I got to the the exchange surgery, there were three things. It was, okay, are the implants going to feel like breasts? Are they going to look like breasts? Are they going to be the same size? You two can understand, I was 500 cc's on the left side, 600 cc's on the right side. I wanted to go in the middle to 550 until a girlfriend said, no, you know what, implants weigh more. They're heavier than your natural breast. So it was like, okay, let's do 500. I wanted to be 500 on both sides. Surgeon told me, plastic surgeon told me, hey, we're going to take in, she stopped at 400 for the fill. She said, we're going to take in a 500, 475, and a 450. Okay, we're taking three different sizes. The left side, the radiated side, less elasticity. They could not put 500 on that side, even though my original breast was 500, couldn't do it. So the left side is 450 and the right side is 415, okay? So I was like, well, okay, they kind of feel like breasts. They don't feel like the expanders anymore. They look like little mounds to me because they're smaller than I was before. But they looked better. So they look better. So when I'm going to her, when I'm going to her for the fills, 1 week she said, okay, she said, we're gonna do the fat grafting after the expansion, the exchange surgery. And I said, huh? And she said, yeah, you know, there's 3 surgeries. I said, 3? Wait a minute, time out. You said we were going this route because I would have less complications on the back end versus doing mastectomy to direct implant. And she said, okay, the first surgery was when you had your mastectomy and the expanders went in. That's the first one. She said, the second one is the exchange. She said, but we like to wait 3 months to see how the implants settle before we go back in and do the revision surgery of where, you know, we need to clean things up, you know, if there's any concave areas, you know, areas that need fat grafting, you know, we'll take care of all of that then. I'm like, like, seriously? I thought you told me I could have fat grafting at the exchange. And so she says, yeah, no, I don't think we're going to do that. So now I'm upset because I have to have this third surgery. So Dr. Mo says, you know what? Just wait until you're there. But, because I said, well, I'm going to wait on that. And she said, well, sometimes people say they're going to wait and they don't go back. So I'm scheduled for September. Hopefully COVID does not come back raging in this area so that I can have that surgery done, because I want to get 3D nipples, okay? I didn't do the nipple sparing because I had small nipples. You could barely see them. So 3D, I'm a bling across the room, okay? and the guy that I'm going to, I mean, people come from around the world to go to him because he's that good.
Are you going to see my buddy Vinny in Baltimore?
Yes,
Vinny, tattoo guy.
Yes.
He sounds like a mobster. And his tattoos look more real. His nipples look more real than real nipples.
Yes.
You'll be so happy.
Yes. So, but I have to wait 6 to 9 months before I can see Vinny. So it's like, okay, let me go and get this revision out of the way so that I can move on. And hopefully by next March, it will be a year and everything will have been done. Now, the one thing that she did say with fat grafting is that your body, sometimes it's like she will go in and do more versus less because she wants to make sure there's enough left so that it looks fine.
Right.
But what I will say about my doctor, my plastic surgeon, is that she answered when I went to see her. I was with her for like 2 hours. She answered every question that I had. In fact, most of them she had already addressed up front. Wow. So the one thing that I did this time was that I had my questions, okay? So that, I knew over versus under, I knew, direct versus expanders. So I knew a lot of things and that was helpful. Now, Dr. Mo told me, because I was like, oh, I'm not sure I like these implants. She said, you need to wait for a year because no doctor is going to touch you in less than a year. So hopefully in a year, I will feel better about these mounds.
They will settle a bit. They will. They're going to shift. They're going to do some things once they get settled in, and then Dr. Griffin can weigh in on this. It doesn't have to be a year, but before you go doing a lot of tattooing and other nips and tucks and things.
Yeah. You want to know where that final position of the implant is going to be. She's right. I mean, I wouldn't wait a year. I don't. That's not true. I've never waited a year. But certainly 3 to 6 months to allow things to settle, and then, you don't want to determine preemptively where those implants are going to settle. So, and then the other thing is about the fat grafting. I typically do it at the second stage. I don't do a third stage unless they really need it. I've had pretty good results with doing them, the fat grafting at stage 2 at the exchange. And what you were speaking of with, it's called overcorrection, basically putting in more fat than you think that you need, because essentially, even if you use a revolved device and we're purifying those fat cells in Lake Minnetonka, you're still gonna have a good anywhere from 20 to 50% of the fat cells that dissipate or may just go away, and that's just fat grafting everywhere,
Can you guys talk a little bit about the nipple things? Like, because now, now, I mean, 8 years ago, they didn't even preserve nipples, but now you can preserve them sometimes if your cancer allows for it. And
Sure.
Also, I'm not sure, Yasmin, if you were talking about getting nipple tattoos, or actually, I had a friend who got nipples made out of tissue, so they had sensation. So I think there's a lot more choices now than when I was sick,
So Ricky, you basically talked about 3 entirely different things.
Mm-hmm. Yeah.
The first thing you talked about, so the nipple tattooing, that's not a new thing.
I chickened out 3 times. I already paid for it, and I've chickened out 3 times. I'm afraid I don't want to feel like
I'll come with you, Breasty. Don't worry.
All right, come with me.
So there's nipple sparing reconstruction where that's actually your real nipple that's maintained during the mastectomy process, and that's your candidacy is going to be determined by the nature of the tumor.
Right.
essentially, us as plastic surgeons and breast surgeons as well, you know, we look at two things. How far with the tumor burden and how far is it away from the nipple? It has to be at least 3 centimeters away. And the amount of ptosis, or the degree that the breasts hang. It can't be, you can't have more than grade 2 ptosis. You're just not gonna have a good result. The nipple's not gonna wind up in the right place. So the smaller breasted women, smaller tumors are more viable candidates for nipple sparing reconstruction.
Although we
Yeah.
are, we
Great
are
prospect
starting to
as
do
well.
reductions. We
I'm
will
sorry?
do reductions now. We'll do the lumpectomy, do a
Yeah.
bilateral reduction, get your
Yep.
nipples point here. We can do a breast
Oncoplastic
reduction
reduction.
with your lumpectomy, get your nipples here. And then
Sure.
we can do in a separate operation, your mastectomy, keeping your nipples as long as the tumor is not near the nipple. So for patients for whom it matters, there are ways to do it, but the sensation, you know, only up
Oh,
to
yeah.
25% of patients will retain their nipple sensation. And I think that number is even
Yeah.
inflated. That
I
came
haven't
out of
had anybody maintain their sensation, but they're happy, you know.
a couple.
It's window dressing, but it's their actual nipple, the
Right.
actual pigmentation.
Mhm.
Now delving into nipple reconstruction, which is something if I were to do a third stage, I would do a nipple reconstruction at a third stage. And there's probably there are at least 25 different, if not more, different ways to reconstruct the nipple. And there's no right or wrong way to do it. It's just whatever the surgeon is comfortable with. You know, I do what's called a CV flap. So it's basically like origami. I'm rearranging the tissue to create a nipple mound. And then you can even get a tattoo then if you have a darkly pigmented nipple, you can get a tattoo. And then there's 3D tattooing, which you know, I'd be interested in actually shadowing or you know, if he offered a course of any, because a lot of plastic surgeons do nipple tattooing themselves in their office, and you know, I'm
That's
kind of
what I
artistic.
signed up- yeah, that's what I signed up for, the 3D tattooing, and I've
Yeah.
seen. So.
Yeah, I'm kind of artistic, so I'm.
You are very artistic.
Yeah, it sounds like
Your
it's art
Facebook
and science. Yeah, it sounds like you're combining art and science in what you do. I mean, you're looking at, because you're trying to keep us healthy, but you're trying to give us some aesthetics that, you know, that so we feel better about ourselves and feel better about what it looks like.
Sure.
I know we got to get ready to wrap up in a little bit, but I wonder if, sorry, Yasmin, if you can put your questions or your links to your resources, because how did you get this information? You did a lot of research and reading. Are there certain websites that you use that you can put in the comments on Facebook?
Most definitely.
Yep, that would be great.
Okay.
It's specific questions for breasties to ask people who are watching, who are in various, like one lady, she said, I'm so ashamed of my breasts. And I told her to connect with you, Dr. Griffin, or to connect with you, Ricky. But in the comment section on Facebook here, there's a lot of people that are weighing in about these things and they need some support. So, you know, give us 2 minutes of what you think people should know and how they can reach you. Same thing for you, Doc. Same thing for you, Sora, Erica. So that way, if people have questions and want to continue this dialogue, we can do that after the show.
Okay. So I joined a couple of Facebook groups, which were really helpful. I kind of sat back and listened to what people were talking about. And then someone actually posted a list of things to ask your plastic surgeon as well as your breast surgeon. So that was very helpful. I found out about Benny because of a friend here. In fact, interestingly enough, my boss and I were both diagnosed with breast cancer at the same time. She was diagnosed 2 weeks before me.
Wow.
She got information regarding the breast surgeon as well as a plastic surgeon from someone else, who I ended up speaking to that someone else. And she took me through the whole process and explained that she was going to do 3D nipples and she was going to use Vinny in Baltimore. Well, I went and looked up Vinny in Baltimore. Interesting about Vinny, he was going to retire and he got the call that his youngest sister had breast cancer. And so he continued because of her. So, so I have lists that I can send. If you want to reach me, I am yasmincoleman@gmail.com. And I am very open about my experience because so many women of color do not talk about their experience. And honestly, when it comes to reconstructive surgery, there are many women who So for example, people said, oh, once you get implants, you're going to feel so much better. No, that was not me. As I talk about things, other people open up and say, that wasn't me either. But so many people only talk about the good part. And so people are intimidated, and it's like, well, no, that's not me. So with me opening up, people have said, yeah, I can relate to that. So like I said, I'm an open book. I don't mind talking to anyone about what I've been through. And once I feel comfortable with what these foods look like, I won't mind flashing you, because I don't consider them my breasts. They're foreign objects to me. So I have no attachment to them.
Right. Well, you know, what's interesting, because it's something that we talk about with every aspect of breast cancer, and that is self-advocacy. That if you're not happy, call a different doctor, or, you know, look, you do what Erica did. She called her cousin. She called in reinforcements. You don't have to be, you know, you don't have to sit there and not be satisfied with what's going on. And granted, it could involve more surgery, you know, and so you want to be careful about that. But it's okay to say, hold on, wait a minute. I don't like what this looks like. I don't like what this feels like, and get me some help and get some help. And we're happy to always, you know, if you reach out to us on Touch BBCA, we're happy to help you find doctors or whatever you need. And, but it's okay to say, I'm not happy. It's okay to demand what you want. I mean, Yasmin, you're very brave to say, wait, I don't want this. I don't like this. And Erica too, that this is not right for me. So, you know, we tell breastfeeders all the time, you know, you don't have to take it. And, you know, we love doctors, but, you know, sometimes they don't do what we need. And, you know, these guys are the fixers. So.
Yeah. So you know, and I think we put it out there where I work. I'm at St. Mary Mercy Hospital in Livonia. I've been there for 5 years, and I started off, you know, being interjected, you know, ingratiated within their comprehensive breast program. So I became one of that kind of that final piece that was employed by the hospital and was really part of that multidisciplinary team. And I think that's why we have such high satisfaction at my institution, is because of that. There's a lot of coordination. You have, you know, like we said, there's a lot of moving parts. There's the oncologist, there's the radiologist, there's the breast surgeon. You have nurse navigators. You have me, the reconstructive surgeon, and we all sit at tumor board and discuss these cases. So we're all on the same page. And you know, and with that, I think we've been able to achieve, you know, a very, you know, I have an older patient population, and not so many African Americans out in Livonia, but still we have resources, and I think we all work well together. Even saying that we as a part of our program, we are required to offer reconstructive. No matter what, we're required to offer reconstruction to all of our patients. There is no, oh, I didn't know about this, or so I think that works very well. And we just hired 2 surgeons that are microsurgeons that would be doing autologous reconstruction, because I'm not touching that one.
How can watchers reach you if they have questions or want to consult, or want to follow you on social media, want to look at your artwork and other things?
Yeah, so I'm at St. Mary Mercy Hospital in Livonia. As of now, I'm still at the main hospital. Number 734-655-3000 if you want to make a consultation.
Can you put it in the chat? Can you put it in the comments?
Sure thing.
You can do it after the show.
Now, in my personal Instagram.
Are you on the Instagram and the Twitter and all that stuff?
No Twitter, but
Tried to find
my personal Instagram is Dr. Griffin Plastics Arts. So you want to follow me, and yeah, my artwork is on there, and some comedic things. The last thing I want to say is I just found out last year about Sister Strut, and I think that's a great resource for African American women who are going through breast cancer, and increase awareness and some of the deficiencies in care that African American women receive, and it's a great support system. And I went there last year, participated in the rally, dedicated it to my cousin here. I had no idea, so I'm going to be more active. And I am an ambassador, the Oakland County ambassador of breast cancer this year.
Great.
COVID kind of put a kibosh on that, but we're going to make something happen.
Cousin, how can we reach and follow you for questions or support or concerns?
So I am, so let me, I'm going to answer that question, but let me just be really quick here for folks that are saying, you know, they don't like how they look and that sort of thing. If anyone saw my post, I'm a very private person. So this is way outside of my comfort zone. However, what I will say is that, you know, my desire to help those that look like me through this thing called cancer. First of all, I don't want anybody else to be in the club, but if you're in the club, my desire to help you is much greater than my fear of doing this sort of thing, right? And so I am open. I have benefited from Sora Yasmin's Facebook group. So like herself, I'm in a lot of Facebook groups, which with different ladies that are sharing information. I am on Facebook. You cannot find me though, so I need to change my settings because again, I am a private person, but I am Erica Davina at Facebook. And so what I will do is I'll put my information in the chat and I'll change my settings so you can actually find me. But please, if I can be of assistance to you or anyone, please feel free to reach into me. You know, it is absolutely my honor and my obligation to pay it forward and help.
Love that. I'd love to circle back with both of you in 6 months to a year and see how you're feeling and how you're doing and how your range of motion is and what advice and what pros you have.
Well, let me just say this, you know, I still have my garment on, but with this round, before I was stuck, just to be clear, my doctor won't let me raise my arms above my head, but they can go up and I can move and I can, you know, put my own shirts on and everything. So ladies, if you are in pain, if you don't like your outcome, if you feel like something isn't right, please get a second opinion or a third opinion or a fourth opinion, because you know what, there are doctors out there that can help you.
Yes. Yes.
As always, you can reach me at Dr. Monique Gary on Instagram, the Facebook, the LinkedIn, the Twitter. I got a YouTube channel apparently, and can't keep track of none of it.
And my horizon.
But you can find me. I'm around. If there's anything I can do as far as, you know, telemedicine has revolutionized what we can do for patients. So
right,
absolutely.
Consultation, if you have questions, if there are things that we can do as Black doctors to help folks who are watching here on blackdoctor.org, we are so happy to support you and to help you with that. And Ricky, tell them about Touch. Give them the wrap up.
So you can reach us at Touch BBCA, at Touch BBCA on Facebook, Instagram, and Twitter. You can reach out to me at Ricky at Touch. You know, on Twitter, I'm Ricky Dove, RICKIDOVE. We'll help you however we can. You know, we are all about eradicating Black breast cancer. It is a different disease, and we want to make everybody know that and bring attention to it and get rid of it. I say that every week. And I just want to thank Amgen for sponsoring our show and giving us support. And I love you, Dr. Mo, and I love you, Breasties. And as Erica said, you know, this isn't a club that you want to be in, but once you're in it, it's unconditional breastie love. So we're in the show with our breastie love, right?
It's true. I got to shout out Florida A&M University and those Rattlers because, you know, we were raised down on the hill. And if it weren't for Dr. Leonard Johnson, to whom I'm dedicating this show, Dr. Johnson, I would not be a doctor today. And so we hope this has been relatable, reliable, real. And the doctor's in every Wednesday, 6 p.m. Eastern Standard Time on blackdoctor.org. We will see you next week. Thank you for joining us.
Thank you all. Thanks for being with us.
Thank you. Thanks for having us.
Bye.
Bye-bye.
Bye.
Bye.